Thank you. And we have Dr. Γκόσιος, who is going to present the third case and the fourth case. Right.
Καλημέρα και από μένα. You'll excuse the cheeky title. So our first case is about a 56-year-old man. He was admitted in our hospital with acute heart failure. Also presented with acute renal failure, and he had known COPD, which was exacerbated. He had a long prior history of presumed heart failure, preserved ejection fraction. Obviously, he had paroxysmal AF, and he had AF on his admission. He was hypertensive. He had been admitted about 3 months prior to this admission to another hospital where he had an angiogram which showed non-obstructive coronaries. He was a patient with known COPD as being a long-time smoker and overweight. So he had a full profile of a heart failure patient with preserved ejection fraction. We always tend to ask about the family history. He didn't have any family history of early cardiac disease. So he was admitted in our ICU being profusely edematous, orthopnoic, he had AF, he had high blood pressure. So all these things were were controlled. He was cardioverted, his blood pressure was controlled, he was diuresed. He did present with low-grade constant troponinemia, had very high NT-proBNP values. So sort of an everyday high blood pressure, heart failure patient being admitted in the ICU. And he did well, but when he was stepped down to the wards, he still remained short of breath. So we thought about taking a second look at him. His ECG was, I would say, more or less unremarkable. So we did another echocardiogram, which showed relatively normal-sized LV for his size. The left atrium was dilated. Perhaps you can appreciate that perhaps the inferior septum may be slightly thinner. And what struck us was mostly the basal inferior wall and the fact that he had rather abnormal strain values. We checked his RV just in case there was any pathology from there. It was slightly dilated, but pulmonary embolism had been excluded. He didn't have any regional wall motion abnormalities at the RV. He had severe diastolic dysfunction, so it was grade 2 diastolic dysfunction. He had a big left atrium with reduced strain. And then we turned our attention towards his pulmonary problem. So actually credits to Dr. Parharidu, who always looks very closely to her patients. And because he wasn't improving, we said, let's have a look at his lungs. So as you can see in this CT, has got multiple lymph nodes in the hilum and the mediastinum. And he's got ground glass appearance, some areas of hyperinflation. He's got infiltrates at the lower lobes. So putting this together with the fact that he had undiagnosed heart failure with preserved ejection fraction, an area of hypokinesis which could not be explained otherwise as a consequence of coronary disease plus lung disease, we thought about doing an MRI. So the MRI, more or less in the scenes, confirms what we saw on our echocardiogram. But what was interesting was the late GAD imaging, where he had significant patches of, I would say, almost transmural enhancement at the infero and anteroseptum extending into the inferior wall. And this is a pattern you probably will see in sarcoid. So we thought about chasing this even further by doing a PET scan. And the PET scan, the patient was appropriately prepared because sometimes some PET scans come back as positive due to inappropriate preparation. But in our patient, it did light up, especially in the areas that were enhanced on GAD imaging on MRI. So he had basal septal and lateral wall enhancement, and possibly you could see a small...
Can you point, Thomas,
Yep.
the pathologic areas?
Mm-hmm. Let me just find the pointer. Okay. So this is the septum, this is the more towards the lateral wall, and this is possibly the right atrium. The thing is, however, that we don't have any other areas. Usually you would expect lymph nodes to light up. We didn't have any lymphadenopathy, at least active. So we established a putative diagnosis of cardiac sarcoidosis because it is a condition that does affect these areas, the basal septum mainly, or perhaps the lateral wall as well. He didn't have anything remarkable in terms of any eye problems. He didn't have any skin lesions. And as I said, the problem is that he didn't have active lymphadenopathy. Now, in order to diagnose sarcoid, there are multiple criteria, and they are different in terms of sensitivity or how easily you can establish a diagnosis. Possibly the most weighted ones are the HRS ones and the Japanese Ministry of Health ones. And if you look at them, all of them require a histological diagnosis. And that's actually a big problem in our case, because if we decided to do an endomyocardial biopsy, sarcoid is it affects the heart regionally. It's not a global disease. So the yield of positive biopsies is less than 20%. He does present with secondary findings, but he does not fulfill our criteria. Is this what we call isolated cardiac sarcoid? As I said again, in terms of imaging, he does fulfill the criteria. He doesn't have to always, patients with sarcoid don't always have to have extracardiac manifestations. So some people feel that there's this clinical entity called isolated cardiac sarcoid, in which case what we have is active or inactive disease in the heart, but there's absence of any sarcoid in any other site, including the lymph nodes, the hilum, skin, or eyes. Now, there's always a debate. This is something we can debate because, and this was actually a very nice debate on the Chest Journal. There's a point and a counterpoint. I will go with a counterpoint that there's probably sarcoid is not a disease that so evolves at the same time in all organs. You might have activity in the lungs at one point in time, and then it may settle, and you may start having activity in the heart. So they don't have to coincide in terms of timing. And the other thing is that when we say we have a normal CT or we have no active lymphadenopathy, that does not mean that we cannot detect sarcoid in the lungs. In this study, in 60% of patients who had normal CTs, in 40% of patients with normal CTs, lung biopsies came back positive for sarcoid, and 75% of patients had either a positive biopsy or infiltrative cells on their bronchoalveolar lavage. So what we need to do is establish a diagnosis here, and because it's got major implications. Sarcoid is not an easy disease to treat. You have to make major decisions here. If a patient has sarcoid, we have to consider initiating immunosuppression, and we have to assess what his risk of sudden death is, because as you see, patients with sarcoid have a very poor prognosis if left untreated. This is the consensus document on the recommendations on treating sarcoid, and what it is, as you see, in terms of treatment, it's a very intense program of starting steroids, that you have to reassess the patient with PET scans and adapt your treatment accordingly. And on the other hand, in terms of recommendations for an ICD, obviously you have a strong indication when you have a low ejection fraction, but when you have a preserved ejection fraction, as in our patient, you have to possibly consider an EPS. If the patient develops arrhythmia on the EPS, he's got an indication for an ICD. If the patient has got arrhythmias on his own, you don't really need to go through that process. So these are major decisions to be taken here. And our patient has unfavorable prognostic features. He's relatively old. He's got some septal thinning. He's got abnormal strain, massive late enhancement. He's got active inflammation. He's got troponins and BNP. He is in heart failure. So he probably would fulfill criteria to start steroids if he had a diagnosis. Is he safe just by having an ejection fraction of 50%? Apparently, no. Even though the guidelines do not suggest the straight up implanting an ICD in these patients, the presence of extensive late enhancement significantly affects his risk of sudden death. And not just the presence, but also the pattern. He presents with a pattern that's the most frequent, to be honest, in sarcoid patients. And these are the patients who have the worst prognosis in terms of both heart failure outcomes and sudden death outcomes. Perhaps one could argue that we can immunosuppress him and that would affect his risk of sudden death by actually reducing the risk of sudden death. It's quite the opposite, unfortunately. The early period after starting steroids is the crucial period when patients develop either the first or a recurrent event, sudden death event, possibly as similar to like a tumor lysis syndrome. It creates instability at these early stages. And then these, in the long term, they seem to settle. So we are troubled, to be honest. We don't really have an answer on what we're going to do with our patient, but we're definitely chasing a diagnosis from the pulmonary part. Treating patients with sarcoid is a challenge. There are a lot of diagnostic gaps. We don't have a definite diagnostic algorithm. Is there truly an isolated cardiac sarcoid phenotype? People argue that there are a lot of differential diagnoses when you're dealing with sarcoid. Mainly ACM is the key one, arrhythmogenic cardiomyopathy. But I wouldn't say that this is a phenotype you would consider ACM. First of all, he's not got any arrhythmias. There is clustering in families. So is there a genetic background that predisposes to cardiac sarcoid? We don't know yet. How can we direct the treatment? Do the patients have to repeat their PET scans over and over again? And obviously we need better models to model the disease. So we're dealing here with an area of major evidence gaps and huge challenges. We need a high level of suspicion, as Dr. Parharidu suspected that there's something wrong with this patient, chased after the patient, and we moved forward into a possible diagnosis. But even then, confirming the diagnosis is a challenge because we need histology and it's difficult to obtain it. So multiple specialties need to be involved: pulmonary, ophthalmology, dermatology, apart from cardiology. And with this, I will leave you with a question on whether you would consider this to be sarcoid and treat as a sarcoid should there not be a histological confirmation. Thank you. Yeah, so he's in the next few days he'll be proceeding to
see them and tell us
yeah.
about the lungs. He's getting an appointment with them. Because we're not.
As you see, Bill, desk finds everything. All the diagnosis, patients.
So, very nice, again, presentation. I would agree with you totally in the controversy. I mean, the Japanese criteria are far too rigid, and they have been superseded, I think, but I'm not sure which group have made proposals.
They've been revised twice.
Yeah, they've been revised. And, I think your last quote, if it's flying, is it a bird, is it a plane, what is it? And if you look and say, what else could this be? Well, it could be anything we've never heard of. But of the diseases we've heard of, you've got lung involvement, you've got inflammation, you've got nodes, you've got cardiac involvement, and your clues right at the beginning, which you said, it's in the base. The involvement is at the base of the heart. There's very little that is disease other than sarcoid that gives you basal problems as the predominant feature. And to quote a minor issue, but we once, and I think Petros Neonopoulos was the main author, but if not, he was one of the authors. We sent a paper to AJC, which was Bill Roberts, the editor, and it was showing echo abnormalities in sarcoid at the base. And this was 25 years ago. And the referees hammered the paper. They said, this is nonsense, it's no good. Bill Roberts wrote back. He said, as you can see, the referees didn't like your paper, but I did, so I've decided to accept it. But for me, it was interesting because this was the immediate clue for me was that and the lymph nodes. So you've got chest, you've got an inflammation chest and basal involvement. And I would treat this as a sarcoid. I would not be quite as precious about, we don't have a diagnosis. What you do is another matter, because as you pointed out very nicely, immunosuppression may be dangerous, ICD, and a lot depends on the patient's willingness. There is a risk. And for my money, it's unusual for sarcoid patients who do not have sustained arrhythmias as a presentation just to die suddenly the way FLNC patients can. So, but it comes down to, if you're 50 years old, how old are you, 50 something?
56.
Somebody said to me, look, there's some chance, it's small, but that plane could crash. Are you going to fly it? No, I'll take a bus. I would take the ICD as a 56. Again, if you were 25, different issue. But very nicely presentation and lots of uncertainties for me.
Yeah, congratulations. We had a similar patient recently, and we couldn't decide if we should implant an ICD or not, and we spent hours and hours. We did an EP study, which I'm not sure if it's worth, but we did it. It was negative. And again, we came back to the same question.
It's actually a big discussion. EP studies in potential arrhythmogenic patients, in clear-cut ACM as well. It's sometimes some people say it's worth performing one. Sarcoid as well.
I think what we miss in all this, as doctors, is we see the patient in one specific period of time. At that time, he may be stable, but he has or she has the substrate, and the nervous system changes always, and the disease progresses. And okay, we had all the tests negative, and the patient died after a year or so. So we have to keep that in mind all the time.
We tend to value the positive EP study results more, I guess, more than the negative ones.
Okay. Professor Cecchi, do you want to make a comment?
Well, again, once more, it was very nice presentation, so my compliments again. And I believe that, it's always a challenge when you deal with these patients, because, after all, I don't know how many we have seen, but, I have seen really very, very few. The literature, as it was showing, shows a lot of controversy, so we don't know much. But I fully agree with Bill, what he said. Usually, at this point, you just discuss with your patient, you say that, we don't really know how to predict what will happen in the future, and you discuss the options that we have. At least here in Europe, I believe that in Greece, as in Italy, we're not going to pay if you implant an ICD. It's different in Albania or Romania, where this doesn't happen. So, the situation is totally different. But as long as we are able to have this device available, then it's an option for our patients, and it's an option for our citizens. That's what we have now in our hands. But also, I would like to emphasize the fact that something that I learned from Bill. Actually, Bill, the first time I met him in London, he taught me something very important: to collect data. And I went back to Florence and immediately bought, a container, a closet, where to put over all our data. And this was very important for the future, because I always said that. So that's the message for the young students and medical doctors that are present in the room. I don't see them, but I guess they are. And I believe that, you have to collect data and to learn as much as possible for what you see and what is published. Another point which I would like to emphasize, the fact that Bill said that Health Encoded is really responsible with this method to teach us, a lot of new discoveries, like he was showing before for the other genes. And I believe that this is the important message that these guys have to accept and learn.
Just one quick comment. Again, back to the certainty of diagnosis. If there's a wonderful, and I can't remember, but it's a paper from Finland, or maybe it's Norway, but I think it's Finland, where they have access to they reviewed all sudden deaths, and they reviewed pathology in an epidemiological study looking for sarcoid, and then they had control of the diagnosis from the clinical centers, because it's a small country. And they showed that about 15% of sarcoid actually gets diagnosed. So we don't diagnose it. We have criteria that are very, very, very difficult. It's sort of like the early ARVC criteria. They're too stringent. They're very specific. And I would have for me, this is a sarcoid. And I think we need to rethink the rigidity of some of our diagnostic criteria in this population.
Okay. Any questions from the floor? Okay, so we're a bit behind the time, so